Assalamu alaikum. I'm Dr. Nabiha Saeed. I'm a resident clinical hematology at Khan University Hospital. I welcome you all on behalf of my institute in this session of Pakistan Society of Hematology. Today, we are going to talk about the recent updates on benign hematological disorder. So as we all know, this is a field of hematology that covers a wide spectrum of disorders. Some of the examples of these disorders are aplastic anemia, thalassemia, ITP, which we are going to discuss in this session today. I would like to thank Professor Parvez Ahmed from QIH Islamabad, who accepted our invitation on the last moment today. So over to you, sir. Today, he's going to talk about aplastic anemia in Pakistan.
Thank you very much, Nabiha, and special thanks to Natasha. She rang me up yesterday afternoon, और मुझे इन्होंने कहा कि जी वो एक ज़रूरी बात करनी है कि one of the speaker जो है that has dropped और emergency speaker चाहिए. तो इन्होंने एक interesting बात की कि जी ये तो it is your favorite topic, तो shouldn't be an issue. तो मैंने कहा वो फेवरेट तो है लेकिन इतना भी नहीं है कि आप लास्ट मिनट में जो है इस पे टॉक दे सकें. Anyhow, I'll try to justify that. Actually, I chose this topic basically because of two reasons. One, that it gives a fairly general information on the aplastic anemia spectrum in our country, and secondly, I've done some work on this cohort of cases that I'm going to present here. Actually, this talk was given in the recent past at an international conference in King's College. I and Professor Salman, Adil, we represented Pakistan. And the topic was the same, aplastic anemia in Pakistan. Since I have been associated with this is one of the recent addition in Center for Hematology and Bone Marrow Transplant. Actually, there's a dearth of facilities in the public sector, and this is going to be, inshallah, comprehensive facility for the diagnosis and management of blood diseases and the bone marrow transplant facility. Now, coming to the incidence of aplastic anemia, we used to read in books that it's a very rare disease till I landed up in hematology. And I found there General Masood Anwar, my teacher and a mentor. He used to work on aplastic anemia in late 80s and early 90s. And the incidence is stated to be 1.5 to 2 million per million, 2 cases per million per year in Western Europe and America. But even the West European consultants, hematologists, once they came across the Asian population, it was their perception that the incidence is more among the Asians. In one of the studies in Thailand, they found 3.9 to 5 million. It was a reasonably large study, prospective epidemiological study. And in Malaysia, it is 5 per million. Chinese study, they have found 7.4, one of the highest in the world. And this is a nice paper by Kojima on why the incidence of hyperplasia is higher in Asian populations. Now, there are various possibilities. One could be drugs and toxins. We, in our student life, used to, read that once you take the chlorambucil and sulfonamides, they can cause aplastic. I haven't seen even a single case of aplastic anemia coming out of use of chloramphenicol. Then there was, various studies haven't shown much association with drugs and toxins. Hepatitis data shows that the aplasia following hepatitis is the same almost in Europe and in the Asian populations, though the hepatitis itself is more in Asian populations. Then there are 2% inherited bone marrow failure syndromes in Japan among the aplastics, but probably the situation is a bit different here. We'll talk of the HLA types, aberrant cytokine expression, polymorphism among the glutathione genes, and the FAS and FAS ligand pathways causing apoptosis. This is the first epidemiological evidence pointing towards the genetic predisposition. This is a study in the British Columbia in Canada. They studied the population below 14 years of age, children, and that they found that among the Southeast Asian descent children, the incidence was 6.9. Among the South Asian, the East Indian descent, it was 7.3, while the incidence was 1.7 per million per year among white and other ethnic groups. All they live in the same environment in Canada. Of course, the difference was among the genetic makeup. Now there have been studies finding association with different HLA types. We know there are various HLA types that are more common in certain populations. This is a Chinese studies on 96 patients. They found that HLA 8, 2, B13, DR beta 1, 7, 9, and 15 are associated more with aplastic anemia. Their prevalence is more among the aplastics than with the control population. Pakistan is situated at the junction of the South Asia and the West Asia. Now we can be part of the Eastern Mediterranean, or we can be part of the Asia Pacific. Personally, I think it's more logical to be part of the Middle East and Iran than to the Australia and New Zealand group. It is a nice country with a diverse population. You see the weather ranging from the below freezing temperature to plus 50 in the summer. A very heterogeneous population and the weather as well. Beautiful country. This is the population pyramid of Pakistan. Almost 60% of the population is below 25 years of age. Now, once we say that the aplastic anemia is more among the younger population, maybe we have got more younger people in our population. This is the population pattern of the UK compared with this. This is a bit older. If you put in the recent pyramid, we have got even more younger population. But still, my perception is that even if we take it as a confounding factor of majority of people of younger age group, even then it is more common among the younger people. Now there is no registry, as we know. Most rural population does not have any access to the adequate diagnostic facility, and not all people are diagnosed. Pakistan Bureau of Statistics says that only 45% of patients for any disease reach tertiary care facility in Pakistan. More than half would not come to the tertiary care centers. In 2017, we did a study when we collected data from all the tertiary care centers. The people sitting here, they all contributed. And we reported 651 new cases of aplastic anemia in 2017 in all the major tertiary care centers from all the provinces. But we did not include the secondary care centers, and the people who did not came to the tertiary care center, they were also excluded. And if we extrapolate that with our population, at that time we calculated that it was around 5 per million per year. Majority are younger, have severe and very severe disease and do not reach tertiary care centers. At AFBMTC, we have registered cohort of 1,810 patients. It was till August 2019, and the number have grown, must have grown by now. This is the around 130 to 150 patients per year coming to FBMTC. These were during my last 5 years of service. I presume the number has must have been swollen by now. This was the catchment area of the cohort that we studied. It is around 40% of the northern half of the northern part of the Pakistan. What we did, we started the study in 2001. Once we established bone marrow transplant center. In fact, General Sultan was started in early 90s or even late 80s. Once we started bone marrow transplant center, he gave me a file and said that we have almost wasted a decade without doing anything. Now we are free to do some clinical work as well. So let's see us start doing a serious epidemiological study on aplastic anemia. And we devised a very comprehensive proforma. This is a 6-page proforma giving all the details of epidemiology and management as well. And these are the number of cases. We started off with 17 cases, and it has gone to, close to 200 cases per year. Now, we analyzed 1,324 cases. I think this is one of the largest collection of patients of aplastic anemia in the world. There have been certain limitations, some even major limitations, but even then, since the population group is quite large, it gives some useful information. There is male preponderance. Even if we count for the preference for our population to seek treatment for the male children, even then we can't account for 75% of the male population among that. And that's what I was saying, that almost 37% of the patients, they were between 15 to 24 years of age. And if we take our national population statistics, that population accounts for around 20% of the population, this particular cohort. So there is disproportionate representation of younger people in aplastic anemia. Again, this has to be taken very, very cautiously. Linguistic groups. There was preponderance of the relatively higher percentage of Pathan ethnicity compared with their population in Pakistan. But since most of these people, they live in the northern part, so it could be the reason. Though my perception is they have got more consanguinity compared with other populations, and maybe they have got a bit more aplasia, but definitely not twice their representation. This is just the spread out of cases. Now, coming to the living community, socioeconomic status, education, occupational groups, these are all, they match our national statistics. There is hardly any difference. Same as with the consanguinity, nutritional status. Maybe consanguinity is a bit slightly more common, around 55 compared to around 50 for the general population. But most of these parameters are same as for our population. The strange thing that we find here is that 80% are either severe or non-severe aplastic anemia. Maybe the non-severe one, they don't come to the tertiary care center. This may be the reason that the patient with severe and very severe, they'll end up in the tertiary care centers. Other do not come. That may be one of the reasons. But almost, 45 to 45% non-severe, and another close to 40% are very severe aplastic anemia. And again, male to female difference among all age groups. Now, association exposure, it was seen in close to 500 people. And pesticide, since majority came from the rural population, and use of pesticide among the agriculture worker is very common. It's extremely common. Almost all the crops, they require spray of pesticides. So we can't relate with this particular exposure. There was no temporal relationship of exposure to pesticide and other chemicals with the onset of aplasia. Small number had piercing, and we had 40 patients. They had aplasia following hepatitis. 20 had simultaneous malaria as well as aplastic anemia, but I don't think there is any association. They just contracted malaria, that's all. 7 as other infections. 6 patients had some concomitant autoimmune diseases. In 6 patients, it followed the pregnancy. Close to 2% patients, they had exposure to antimalarials. Another 1.4% had taken traditional medicines, analgesics, antibiotics, and antiviral, very, very small fraction of patients. So coming to the conclusion of this large epidemiological study, majority of our study population belong to lower socioeconomic stratum, as it is in the general population. They had rural background. There was high rate of consanguinity. That's not strange. There was no association found with previously recognized agents like drugs, industrial chemicals, and pesticides. Younger age, male preponderance, and higher consanguinity point towards genetic factor in aplastic anemia among our population. This is my assumption. Now, the genetics, underlying genetic, with the factor of cytotoxic T cells, autoantibodies, and cytokines, they all mount immune response leading to the destruction of the hemopoietic cells. Now, we did some work to find out some genetic associations in aplastic anemia. This is a study that was done in KRL, IBG, to find out the polymorphism in the glutathione S transferase enzyme, GST-M and GST-T polymorphic, to find out whether there is deletion of these the genetic genes that are related with the glutathione pathway. And we studied 137 patients and 220 controls. We found significant association with GST-M not variant in aplastic anemia that was close to 50% compared with 30% frequency among the controls. Once we did the meta-analysis of these 2 genes among various studies, published studies, there was some association with the GSTT not variant of this glutathione pathway. This is the cohort, a small cohort, finding association of HLA. We need to do a bit more work because we have got large number of cases with HLA results, in which in this particular cohort, we took the 61 patients and 200 control group. And we found DRB 15 that is already reported. It is more among the patients compared with the controls. And another finding was that DR beta 1 3 was more among the controls compared with the patients. Now, whether it has got some protective role or not needs to be studied. this is the single nucleotide polymorphism studied in the apoptotic pathway, FAS and FAS ligand, as we know the FAS ligand on the cytotoxic cells and the FAS receptor on the target cell. Any mutation there can cause some defects in the apoptotic pathway. And we studied two target genes, RS1800682. This was in the FAS, and this was in the FAS ligand, RS5030772. And this AG was more 62% among the patients compared with 21% among the controls. Similarly, this variant AG was less 7.6% in the patients compared with the general population. So these are two clues that there may be some underlying genetic defects. This is another cohort of patients, 214 patients. We did this study with the Neil Young group at NIH USA, and we did try to find out some genetic lesions and some association of cytokines. And we studied 9 cytokines. Out of the 9 cytokines, 2 cytokines, GCSF and thrombopoietin, they were very high among the aplastic patients. Of course, this is a secondary phenomenon, unlikely to be related with the disease etiology. And rest all the interferon and interleukins, they had the normal values, the same values among the patients as well as the controls. Now, these out of this 214 patients, 10 abnormal variants among the TERT and TERK gene were detected, and 2 of the variants, this one, exon 3 and exon 5, they were the novel mutations, not yet reported earlier. These were the novel mutations, rest were known mutations. So since this is a vertical or longitudinal, I would say longitudinal follow-up, we did notice the transformation. 3 patients evolved into PNH, AML, 11 into MDS, and 9 into AML, 3 into PNH, and 11 into MDS. This was a disease evolution that we noticed in our cohort. PNH, significant PNH was in 52 patients. Now, what are the challenges in the management? As we know, there is delayed diagnosis and referral. There is a lack of quality transfusion services, high transfusion burden. People receive the whole blood transfusion, multiple platelet transfusions. There are multiple infections, resource constraint, limited transplant centers. I mean, all this compound and lead to what we see here: graft failure, GVHD due to high sensitization, aluminization, infectious complication, and unfavorable outcome. Our patients before transplant are not as clean as are in advanced countries. So these are the, broad principles of management of aplastic anemia. I'll not go into the detail, just briefly. Exclude inherited bone marrow failure syndrome, especially hypoplastic MDS, PNH, and hypoplastic acute leukemia is very important. Define these disease severity precisely, assess fitness and comorbids. Then we have got the supportive treatment. Patients who are seriously sick have got comorbids, just go for supportive treatment. Then low intensity treatment, again, this population can be given, say, eltrombopag or cyclosporin alone. Then there is option for using triple immunosuppressive therapy using HARS ATG, cyclosporin, eltrombopag, then allogenic LOBMT upfront. This is the treatment of choice for majority of the patients. And one important message is do not take to BMT in the presence of infection. If there is significant significant infection in aplastic anemia, do not take the patient to BMT. The patient is unlikely to make it. Now, these are the challenges in supportive treatment. There are functional constraints. Leukodepletion is not available. People transfuse whole blood, and the relative, they donate blood and lead to the sensitization and aluminization. Increase donor exposure due to random platelet transfusion, prolonged waiting time, pre-transplant, and recurrent infection. These are the challenges. Immunosuppressive treatment, HARS ATG, though available, it's not freely available. Rabbit ATG plus cyclosporin or cyclosporin alone, not very, useful in patients with very severe aplastic anemia. Triple immunosuppressive therapy using this HARS ATG, cyclosporin plus eltrombopag is an option for patients with non-severe aplastic anemia. They are associated with relatively good outcome. Now, increased infections, requirement for irradiated blood components. This is one of the problem with the immunosuppressive therapy. Then you have to support patients for at least 2 to 3 months till there is some recovery. And by then there should be availability of irradiated blood components and prophylaxis against infections. And some of the patients would die during this window period. Then issues with the IST is that around 50%, 15% would relapse and 10% would evolve into coronal disease within 5 years. Though the HARS ATG is better for the immunosuppressive therapy, but this is one of the CIBMTR publication, and we also participated in this publication, in which it says that in transplant setting, ATG, the rabbit ATG is superior to the HARS ATG. It is associated with less GVHD, both in allo, the sibling allo and the mud transplant, as well as relatively better outcome, especially among the match unrelated donor patients. I'll not go into the detail of this algorithm for its severe aplastic anemia, but I'll just point out to this paper, recently published paper, Aplastic Anemia in Resource Constrained Environment. This is, concise review on diagnosis and management of acquired aplastic anemia in resource constrained environment and pertinent to our country. We published this with the collaboration of Eastern Mediterranean and the European, the Severe Aplastic Anemia Working Party of European Blood and Marrow Transplant Group. It's a nice paper and relatively recently published. And I think I've overshot the time and I'll stop here. This is, one of the earlier paper on infectious complications.
Thank you so much, sir. This was such a great presentation. Now we will have the panel discussion at the end and we'll take the questions at the end. So now we have Dr. Uzma Zaidi from NIBD, who's a consultant hematologist. She will have a presentation on outcomes of stem cell transplant in beta thalassemia. So we'll start with her presentation.
In this event, it's a pleasure to talk about stem cell transplant outcome in Pakistan. I declare that I have no personal financial interest and there is no financial support received from any industry source for this presentation. This is the outline of my presentation. I will be focusing mainly on the outcome of beta thalassemia major from different centers in Pakistan. Stem cell transplantation, as you all know, is a process in which healthy hematopoietic stem cells are infused in a recipient who is a diseased person to rescue the hematopoietic and the immune systems which have been damaged or destroyed by the toxic doses of chemotherapy, which is given to the patient for the treatment of any lethal disorder like acute leukemia or lymphoproliferative disorders. The first stem cell transplant was performed in early 1960s by Donald Thomas and his colleagues from Johns Hopkins in USA. He basically performed a series of 6 transplants for different hematological indications like chronic myeloid leukemia, chronic lymphocytic leukemia, and multiple myeloma. Unfortunately, none of these patients could sustain engraftment because at that time, there was very little information available regarding the optimal conditioning regimes and the role of tissue antigen matching, measures for control of graft versus host disease, and the sources of stem cells. This series of experimental transplant actually opened doors for the investigators to search and think about the different aspects of stem cell transplant. And the major advancements in transplant occurred between 1970s and 1980s when different study groups explored different types of conditioning regimes and the sources of stem cells. Cord blood transplant was introduced in this era, and newer techniques for HLA typing were discovered, which led us to understand the different combinations of recipient and donor groups which can be transplanted. The first stem cell transplant, the first successful transplant for thalassemia patient was performed in 1981, again by Johns Hopkins and by Dr. Donald Thomas and his team. And by that time, conditioning regimes were well defined, and this patient received myeloablative conditioning with busulfan and cyclophosphamide, and he was the first survivor of transplant for thalassemia. According to the CIBMTR database, as of 2020, worldwide, approximately 30,000 to 40,000 transplants are performed yearly. And this number continues to increase by 10 to 20% every year. And as of now, around 20,000, more than 20,000 patients are have survived 5 years or longer after transplant. And this includes both allogenic and autologous transplants. In Pakistan, the first stem cell transplant was performed by Dr. Tahir Shamsi and his team at Sultan Hospital, Karachi in 1995. It was an autologous stem cell transplant, which was performed on a young male who was suffering from acute myeloid leukemia. Basically, the journey of stem cell transplant in Pakistan began in 1995. This graph basically summarizes the overall transplant activity in Pakistan over the last 25 years. And if you see here, in 1995, we had only one functional transplant center, and the number of transplants was less than 100 at that time. Gradually, with the passage of time, new centers evolved. The second center which started transplant was Armed Forces Institute of Bone Marrow Transplant in Pindi. They started their transplant program in 2001. After that, Khan University Hospital started its transplant program in around the end of 2003 or 4. And then in 2009, PEMS and Shifa International started transplants. And now in 2020, we have 11 functional transplant centers in Pakistan. And you can see that the number of transplants is rising in a positive trend, and starting from less than 100 in 1995, we are now touching a figure of 3,000 transplants in 2021, which is, I think, a very good figure in a developing country scenario. In contrast to the Western countries, where transplant is mainly offered in malignant indications like acute leukemia, chronic myeloid leukemia, and lymphoproliferative disorders, In Pakistan, the primary indication of transplant still remains the benign disorders like hemoglobinopathies and bone marrow failure syndromes. And the main reason behind this is the strong cultural norm of consanguineous marriages, which result in increasing rate of inherited disorders like thalassemia. The major disease burden for transplant is caused by hemoglobinopathies in Pakistan. Presently, all the transplant centers which are functional in Pakistan are located in the province of Punjab, mainly, and in Sindh. Unfortunately, there is no transplant center in Balochistan and KPK, which are the two major and big provinces of Pakistan. And as a result of this, the major chunk of patients from Balochistan is referred to Karachi or Sindh for treatment, whether it's transplant or whether it's supportive care. And patients from KPK are mainly referred to province of Punjab for treatment. So we need to develop more human resource, trained BMT consultants and staff so that we can develop new centers in these two provinces, and this will, help the deprived population of Punjab of KPK and Balochistan to a great extent. This slide shows the outcome of beta thalassemia major from different centers in Pakistan. Highest number of transplants for beta thalassemia is performed at AFBMTC between 2001 and 2020. They have performed 309 transplants and they use standard conditioning USI along with hyperchelation when needed, and their overall survival is around 78%. Ahmed University Hospital has performed 46 transplants over the last 15 years, and their overall survival is 86.7%. Shifa International started the transplant program in 2009, and they have done 12 transplants using different conditioning combinations, and the overall survival is 60%. Kajazam International Hospital started transplant program in 2017, and they performed 27 transplants up till now, and the overall survival is 92.6%. And thalassemia-free survival is 85.2%, which is remarkable. I think it is comparable to any other developed country. IMS has done a large number of transplants for thalassemia, starting from 2009, and their overall survival is 90%, and they are using Bucy along with ATG and fludarabine. Children's Hospital Lahore started pediatric transplant center, pediatric transplant unit. It is the first public sector transplant center, and it became functional in 2018 under the supervision of Dr. Tahir Shamsi, and currently Dr. Nasir is leading the transplant unit. They have performed 23 transplants for thalassemia, and the overall survival is 82%. NIBD Lahore became functional in 2016 under supervision of Dr. Tahir, and Dr. Naseem is leading the unit. And there they have performed 14 transplants for thalassemia, and the overall survival is 80%, which is pretty good. This is the data of NIBD and BMT over the last 10 years. We have performed more than 500 transplants in different indications. The main indication, of course, remain aplastic anemia and beta thalassemia, followed by acute leukemia. More than 100 transplants for acute leukemia patients have been carried out in NIBD. Other indications in which we are doing stem cell transplant are rare inherited disorders of metabolism and Fanconi's anemia, and autologous transplants for lymphoma and multiple myeloma. This is the airwise distribution of beta thalassemia transplants between 2010 to 2020 at NIBD. Total 204 patients of thalassemia received stem cell transplant at NIBD in the last 10 years, out of which 157 transplants were done with matched sibling donors, as the remaining were haploidentical transplant. Haploidentical transplant program was started in the end of 2014. These are the pre-transplant characteristics of the patients. And if you look at the division of patients according to the risk stratification, majority of the patients who have been transplanted fall into PISARO 2 risk group. And there's a significant percentage of patients of thalassemia who belong to a very high risk group. I will show you the difference between these the three risk groups. Basically, PISARO group, it's a European group. It described a PISARO classification in late 1990s to predict the outcome of stem cell transplant for thalassemia major. And this classification depended upon three risk factors: hepatomegaly, irregular iron chelation, and portal fibrosis documented on liver biopsy. And based on the presence and absence of the risk factors, patients were categorized into class 1, class 2, and class 3 risk groups. And the class 3 group harbors the highest risk of graft rejection after transplant. This PISARO classification was validated in pediatric population of European countries only. And unfortunately, this classification is not applicable in a developing country scenario like Pakistan, where optimal health care for thalassemic patient is not available. So there was another a very high risk category, or a very high risk group of beta thalassemia was defined by the PISARO group, having age more than 7 years and a liver size of more than 5 centimeters. So unfortunately, in a country like Pakistan, 20 to 30% of patients coming to transplant centers fall in this category. And this is the group of patient which has a highest risk of primary graft rejection as well as transplant-related mortality, because they are heavily iron overloaded. Their organ function is compromised most of the time, and they have massive hepatosplenomegaly, and they have irregular iron chelation status. So this is the group of patients which adversely impact the overall survival and thalassemia-free survival of our population. So based on the risk stratification of the patients and our personal experience at NIBD, we have modified or redefined our conditioning regimes according to the risk groups. For PISARO 1 group, we have now switched from ATG bucide to thiatipa bucide based on the current evidence of using thiatipa, which produces significant myeloablative effects. For PISARO 2 and 3, we are using protocol 26, which is a reduced intensity conditioning protocol. And now we have slightly modified the protocol 26 by adding ATG in it, so that we can prevent the risk of late graft rejections. And for very high risk group, as I mentioned earlier, we are using pre-transplant immunosuppression with 2 blocks of fludarabine and dexamethasone, followed by protocol 26-like regime with intensive iron chelation. For haploidentical transplant, if we check the donor-specific antibodies, and if the donor-specific antibody is positive, then we offer the patients pre-transplant immunosuppression therapy along with desensitization protocol. And in patients who are negative for DSA, we just proceed with pre-transplant immunosuppression followed by standard conditioning regime. And of course, in haploidentical transplant, we are using post-transplant cyclophosphamide to prevent graft versus host disease. This is a desensitization protocol. It comprises of 4 steps, basically. In the first step, rituximab is given, and then plasmapheresis, 1 or 2 sessions of plasmapheresis are performed to remove the excessive HL antibodies, and this is followed by intravenous immunoglobulin, which is used to remove the residual antibodies, and then standard conditioning regime is given. This table shows the outcome of thalassemia patients at our center. You can see here that the overall survival from MST transplant is 80.6%, whereas for haploidentical transplant, it is 88.8%. And thalassemia-free survival in MST is 77.7%, and for haploidentical transplant is 75.5%. And this, I believe that this is because of the significant percentage of patients who belong to very high risk group. And as I mentioned earlier, that this is the group which adversely affects our thalassemia-free survival. Luckily, in our patients, both the risk of acute GVHD and chronic GVHD is not very high, and this is because of the optimized conditioning regimes and GVHD prophylaxis, which has resulted in a reduced rate of acute and chronic GVHD in our patients. These are some of the limitations that almost all the transplant centers face while practicing. And the most important limitation, the major limitation for our patients in our country is, of course, their financial constraints. Because of the lack of health insurance, most of the patients are unable to afford the cost of transplant. Another major limiting factor is the lack of trained human resource who can perform transplants. So this is a major limitation, and we need to we are working on to improve the human resource. We are planning to train more physicians and people, paramedical staff and the nursing staff, so that we can start new transplant centers in those areas where there's no transplant facility. Another important issue in limiting the number of transplant is the continuous supply of the chemotherapeutic agents and their high cost. The cost is very high. Most of the time, the drugs are not available because of the interrupted supply chain. And this is one of the factors which limits the number of transplants in any center. Shortage of donors means shortage of HLA matched sibling donor for a patient. According to statistics, it has been published previously from Pakistan that up to 50% of patients can find a matched sibling donor for transplant only in Pakistan. And this is the reason why the number of transplants are very limited, because of non-availability of HLA matched donors and non-availability or expertise of non-availability of the expertise for alternative donor transplants. These are some of the steps that have been taken to improve the or enhance the growth of the transplant program in Pakistan. The first and the foremost step just been taken is the establishment of Pakistan Blood and Marrow Transplant Group, and it includes all the senior transplanters of Pakistan. And under the roof of this group or this society, we expect to start post-fellowship training programs in transplant in order to increase the number of transplant consultants, and along with this, training of paramedical staff and pharmacists in BMT is also started in few centers, and we expect to collaborate with international societies for education and academic growth of the PMT teams, and collaboration with World Marrow Donor Association is also being in process in order to develop a national marrow donor registry so that alternative donor programs can be started in Pakistan. Thank you very much for your attention.
Thank you so much, Dr. Uzma. That was such an informative presentation. Now, the next topic for discussion we have is the management of ITP in adults. And for this topic, we have Dr. Usman Shaikh, who is an associate professor at Khan University Hospital. So over to you, sir.
Assalamu alaikum to all of you. I am Dr. Usman from Khan University Hospital. I am associate professor. The topic which is assigned to me is the management of ITP in adult. Overall, the theme of this CME is the benign hematological disorders. However, I just think that all these disorders are not so benign. They are all quite even. I can say for example, aplastic anemia is sometimes doing worst even when we compare to acute leukemias. So same is with ITP. This is not so benign as it seems to, but however, I don't have any financial affiliation or interest. A little bit about the history. It was first described as a dirt on the peripheral blood film in 1892 by Hermann, strange little particles. In 1902, it was connected with the coagulation cascade. In 1928, the origin of platelet was established, that it was originated from megakaryocytes. And Verhoeven disease referred to Paul Corbett Verhoeven, the ITP, first time. previously noted as a Verhoeven. These are actually small anuclear discoid particles of 1.5 to 3 micron meter. These are actually the bit of cytoplasm of megakaryocyte, and each megakaryocyte can produce up to 3,000 platelets. Lifespan, the usual physiological lifespan is 7 to 10 days. However, in case of sepsis or hypersplenism, sometimes it remains only for minutes to few hours. So ITP is an acronym for immune thrombocytopenia. However, it interchangeably used as an idiopathic thrombocytopenic purpura, which actually shouldn't be used. The purpura is also misleading sometimes because only 1/3 of these patients usually have symptoms of purpura, and it should be considered in the differential diagnosis when the platelet count is repeatedly below 100,000. Now, it is an important aspect in the management from management perspective. If someone come into the clinic with a platelet count of 100 to 150,000, then my suggestion in that case is that, and as it is already reported, that we avoid invasive testing, and we can just reassure the patient, because only less than approximately 1% of these patients can develop frank acute ITP in future. Previously, we used the term of acute, chronic on the basis of duration. If thrombocytopenia persists for more than 6 months, then we use the term chronic. Now, according to the new guidelines, the first 3 months, a patient with ITP labeled as newly diagnosed. From 3 months to 9 months, 3 months to 12 months, the persistent phase of the thrombocytopenia, followed by chronic phase after 12 months. There is no confirmatory test available to diagnose ITP. So ITP is a diagnosis of exclusion. So isolated thrombocytopenia in the presence of normal WBC and HB. So blood smear examination is very important. If there is a microcytosis along with thrombocytopenia, yes, that especially in the females, that can explain the low hemoglobin because of the iron deficiency is secondary to bleed, microscopic as well as macroscopic. We have to exclude the all other causes of thrombocytopenia, along with if the peripheral blood film revealed macrocytosis, then one should think the differential diagnosis of macrocytosis on peripheral film. Fragmented RBC mean the diagnosis is something else. Malaria, atypical lymphocytes, leukoerythroblastic picture, and most importantly, clumps. Especially apart from, as far as the ITP is concerned, we broadly divided into primary and secondary. And for the purpose of secondary to rule in or rule out, we need some profile, including autoimmune profile, anti-DNA, anti-CCP, and lupus. In what cases we should advise for the bone marrow aspiration and trephine? I believe that in any patient who is more than 50 years of age, and because approximately 5% of this patient with myelodysplastic syndrome can present with isolated thrombocytopenia. Always consider cytogenetic studies, because this is an invasive procedure, and once you plan for marrow, then always also advise for the cytogenetic at the same time. If platelet count fall in the range of 50 to 100,000, then always consider keeping in view the prevalence and incidence of hepatitis and B and C in our population. We should look for hepatitis B and C serology. As I mentioned, peripheral blood film examination is very important. Sometimes giant platelet also noted, and in that case, we should have in mind about the Bernard-Soulier and myelodysplastic syndrome. Apart from, yes, chronic ITP is always in the differential. Some labs have the facility of optical platelet count, and actually, what is optical platelet count? Is that platelet contain RNA, which can be stained with a fluorescent dye using, and we can see those platelet with diode lasers instrument. Now, this nucleic acid staining will enable the system to differentiate giant plated from fragmented RBCs. So whenever there is a borderline low or low plated with giant plated, one should go for this optical platelet counting. Similarly, as I mentioned, that peripheral blood film, we should sometimes we receive consults of patient with the platelet count, say for example 10,000, but otherwise the patient is fine with no bleeding tendency, no hemorrhagic manifestation, and peripheral blood film reveal these columns, which is noted in the slide. Similarly, how to resolve this issue of clumping? Previously, what we were doing, that we use another anticoagulant like citrate or heparin. However, now the latest recommendation is that we should do the vortexing of the sample, which can resolve this issue in approximately 50% of this patient. What are the factors which need to be considered when detecting when deciding on the treatment? First, clinically, we should see the how emergent requirement of the treatment. So we usually, on the basis of clinical finding, we divided it into two broad categories. One is the wet type ITP, the other one is the dry type. The other thing which we look at it, that is the count. Is the platelet count is more than 30,000 or less than 30,000. We also look at the stage of the diagnosis. Either is a newly first-time presentation with acute onset of symptoms versus persistent or chronic. We have to mention the side effect, and we should consider the side effect of treatment. You also need to know about the patient age and medication if he is already on, say for example, anticoagulants or antiplatelets. Financial status and cost of the drugs we should keep in mind while advising the management. And in the last, the patient can ask about the prognosis. So skin manifestation, yes, from resident's perspective, yes, fatigue mean up to 2 millimeter. Size, small red color spot, whereas purpura mean from 3 millimeter to 1 centimeter spots or bleeding under the skin. Apart from that, bruises and ecchymosis. And we should look for and ask for mucosal bleed that include epistaxis, gum bleed, melena, or hematuria, or menorrhagia in case of childbearing age females. We need to, if there is a significant bleeding, then we need to classify according to the WHO definition. As I mentioned, 0 mean no sign of bleeding. Fatigue and ecchymosis is the grade 1. Grade 2 mean there is hematomas or ecchymosis or epistaxis of more than 1 hour. Retinal bleed without any visual impairment. Melena and hemoptysis, all these come under the heading of grade 2 bleeding. Grade 3 mean there is a requirement of transfusion where there is a blood or platelet requirement, and by definition, if there is a fall of hemoglobin of 2 gram of hemoglobin mean, that the patient has major bleed. Grade 4 mean life-threatening or critical, say for example, intracranial bleed or bleed in the eye or retina. Or if the bleeding, sometime rarely, but it can happen in the, as we have seen with low platelet count in the pulmonary tissue, say for example, alveolar hemorrhages. Then grade 5 mean fatal bleeding leading to death. So platelet count, yes, platelet count definitely matters. Mortality increases if platelet count drop to less than 30,000. 10 years back, the risk of severe bleeding was reported at 3% in children and over 70% in adults. The risk of fatal bleeding at 0% and 13% in that study. Now, due to the introduction of the new thrombopoietin receptor agonists like Ultrambovac and immunotherapy like anti-CD20 antibody, the availability of rituximab, the prognosis has improved. And in the latest, mortality is currently in pediatric again, it's just 0%, and adult, it has halved up to 7% when compared to 10 years back. However, whenever we consider treatment, as I mentioned, we need to explain the side effect to patient, especially the steroids. There are numerous side effects, we all know, we should explain to patients. Sometimes psychiatric related issues, sometimes there is this severe insomnia, hyperglycemia, hypertension, moonlight phase, Cushinite phase, so all these things. But it is important to note, we have to give these doses of high dose of steroids for 2 weeks only, and then we have to taper at all cost to avoid long-term side effects. For rituximab, yes, we need to check for hepatitis B surface as well as core total antibody status. And although rare, case series of progressive multifocal leukoencephalopathy are well established. Eltrombopag, yes, we have to explain to patient that it should be taken before meal, at least 1 to 2 hours. 10% patient develop venous thromboembolism, and with the long-term use, there are reports of mild marrow fibrosis. Splenectomy, yes, there is a response rate of 55 to 60%. However, fulminant infections and infestation is a bit concerned. Now, this is, we received a number of consults regarding with low platelet count and when to use or not to use non-steroidal anti-inflammatory drugs or anticoagulants in this scenario. Now, it is important to note that the median age of ITP is 50 years. So many patients are on anticoagulant and antiplatelet. So ITP is a risk factor for venous arterial thromboembolism, which is about 2 times higher in ITP. So this is particularly high when there is a rapid rise in platelet due to any treatment, including steroids or some other sort of treatment. In older patient, it is important to look for VT and ITP with antiphospholipid antibodies. Now, what we usually advise, if the platelet count is more than 50,000, there is no need for any intervention for anticoagulation and antiplatelet until unless active bleeding occur. So more than 50,000 is safe. If patient has a platelet count of 20 to 50,000, then we can give 50% dose. Either is a 50% dose or alternative dosing we can do. And for those patients who have less than 20,000, I advise to stop temporarily until unless there is a rise in platelet in who are on NSAIDs or on anticoagulants. Financial status, as I mentioned, in my previous result also, the steroids is inexpensive, equally effective to IVIG. So this is an important thing. If patient can bear few side effects, then there is nothing superior to steroids. On the other hand, yes, IVIG, but the cost is a hindrance here. At least in a 60 kg patient, it will cost around 12 lakh rupees. And nowadays, sometime just the special indication which we usually see in this patient is the 3rd trimester pregnancy with very low platelet, and the OBGYN people go for a seizure or so, then we usually advise this IVIG. Ultramobag, yes, but again, cost is an issue. It's a sort of a chronic disease. So once a good number of patients actually ultramobag dependent. Previously, there was a program in Sindh from where patient get this medication free of cost, but now I came to know, no, there is no free medication available, and the cost is probably 75,000 per month. Rituximab, again, if you consider for it, 30 to 40% chance of response, and the cost is approximately $500,000. Similarly, splenectomy in different setups, but it is approximately 0.25 million rupees in Pakistan. So in adult, ITP is a long-term chronic course, even a lifelong. These are all ongoing. Just 5% of all chronic patients achieve remission as per ASH guideline in 1996, but now scenario has changed. So today, approximately 50% achieve partial or complete remission. However, there is no marker that can reliably predict a chronic course. When you start any treatment, you can't say, okay, who will going to respond to this medication, to steroids or some other medication. So most of the time, patient presented even with a very low count, but patient have a mild symptoms like some bruises or petechiae or purpura. So if platelet count is less than 10,000, I usually advise for pulse methylpred 1 gram once daily for 3 days. And if the platelet count is more than 10,000, we can give in an adult 30 milligram BD of platelet for 2 weeks, or prednisolone for 2 weeks. Continue for 2 weeks and then taper. However, once in a while in lifetime, there are some difficult cases which I already had seen. There's a wet type or life-threatening type, with intracranial bleeds, then you need to give more than one agent to patients. And sometimes if there is a refractory type of disease, then you even consider splenectomy in these patients. Splenectomy, yes, the best response till to date, which achieve with the therapeutic modality, is the splenectomy. In our series, we noted that approximately 50% patient achieve complete response, and partial response was noted in approximately 36%. Indication is limited because nowadays ultramobility and rituximab is available. That was at 14-15-year-old study we showed this response. So I still believe never push for it except for a life-threatening resistance cases, and always involve patient and family, because if there is a no response to splenectomy, then family create problems as well as patient, because they think the surgical procedure is the ultimate. Then why we are still not achieved the remission? Now, persistent and chronic ITP. Now, what happened? Our aim in that case to keep platelet at least more than 20,000. Approximately 40% of ITP patient ultimately develop chronic or persistently low thrombocytopenia. In case of any surgical procedure, then the cutoff are different, but usually we are quite comfortable with a count of 20,000. Further management is individualized and depend on the financial status. If platelet are less than 20,000, I usually prescribe low dose steroids, because it fills the endothelial gap. So it at least minimizes this serious bleeding. And 10 milligram of steroids usually cause minimal or no side effect to patient. We can give even on alternative basis. Similarly, ultramobac, yes, as I mentioned, there is a dependency on ultramobac. Rituximab, yes, one time, 4 doses, but 30 to 40% response. Azathioprine, yes, my colleague, especially my senior colleague, is very used to give this Imran, but I believe as I review the literature, it takes 4 months and for its action, and there are definite side effect with this drug. I have seen a number of patients who were admitted with pancytopenia, because it is a quite myelosuppressive and also cause macrocytic anemia. So there is an issue with this drug. And splenectomy in the last, yes, we can offer splenectomy. So nowadays the recommendation is that in case of resistant type, or you can say refractory type, we can with IVIG and steroids, then you offer ultramobac. The second recommendation is rituximab, followed by splenectomy. So ABC is nowadays. The other guideline, ASH guideline, has American always create their own guidelines, which somehow very strange. Even these consensus reports from European side, which seems a reasonable option when compare A, B, and C. However, there are some reservation from American physicians. Refractory ITP, yes, if there is a persistently low platelet count, that is less than 30,000, there is no clear-cut definition in the literature. However, in most places, this was taken as a less than 30,000 platelet counts taken as refractory who fails 2 upfront regimens, including steroids and IVIG. However, nowadays, especially in the pediatric as well as in the adult, we have the facility of mutation analysis. And say, for example, many companies now offer just in 40 to 50,000 rupees, all these inherited thrombocytopenia panel, which can rule in or rule out, which is called Eldridge, Bernard-Soulier, gray platelet, and other syndromes like Fanconi, Schwammen-Diamond, dyskeratosis congenita, and so on, as well as MDS. Why? Because a good number of patients with this syndrome and disorder sometimes presented with isolated thrombocytopenia, and as I already mentioned, cost-effective panels are available. And this is from ASH, incidence of primary refractory thrombocytopenia in patient defining as having refractory ITP. And one can easily see out of these more than 350 patients, when they re-evaluated, 50% yes, definitely categorized again in the primary ITP group. But on the other hand, 5% were drug induced, 10% found to have MDS, the other 10% in bone marrow failure state, and 15% in the inherited causes. Now, 2 or 3 slides about thrombocytopenia in pregnancy. 6 to 12% pregnant female develop thrombocytopenia during the course of pregnancy. The most common cause is gestational thrombocytopenia, followed by preeclampsia, eclampsia, and HELP. The next most common cause of thrombocytopenia in pregnancy, accounting for 1 to 4% of all patients, is ITP. Only 1/3 cases have been diagnosed beforehand, 2/3 are detected during pregnancy. One recent study among of 4,000 pregnant females, platelet count decreases by approximately 10,000, approximately 10%. Majority have levels within the normal range, and thrombocytopenia is secondary only to anemia, as is most common hematological abnormality during pregnancy. Why platelet count drop in pregnancy? There is postulated theories, and they say that there is a, yes, definitely there is a dilutional effect as compared to overall red cell and platelet mass. There is a increase in the plasma volume. So there is a dilutional effect because of the rise in the plasma volume. And other thing is that whenever these platelet passing over the trophoblast, some platelet destroy during that process. Treatment. Only about half of all pregnant women need treatment. Treatment is usually based on the duration of pregnancy and bleeding tendency. And there is an indication, yes, until unless the platelet count drop to less than 20,000, you can safely follow these patients just on wait and watch basis. Wait and watch. So if platelet count less than 20,000 in the first and second trimester, then you should intervene. Similarly, however, if the platelet count less than 50,000 in last trimester, then we should consider steroids. However, the dose of steroid is usually, which is suggested, is 50% when compared to a non-pregnant patient. So usually we advise 20 to 30 milligram per day and try to maintain the count above 20,000. Usually we should avoid dexamethasone in pregnancy. There is no experience. The second drug which we can offer to this patient is IVIG in steroid resistance cases. However, again, as I mentioned, cost is a big issue, and especially at the time of peripartum period. Splenectomy rarely indicated for severe resistance wet type cases if possible, and should be performed laparoscopically during the second trimester. For active bleeding, yes, we can offer platelet concentrate then and there. Ultrathrombobag is contraindicated. There are few case reports, but again, there is a case series of 17 patients. In that, there was one case of natal cleft. So we should avoid this because you don't know what someone can do with you if something going wrong. Azathiopine is safe, yes, especially the general concept is that we should avoid all drug in the first trimester, but second to third trimester, yes, you can offer azathioprine, can be given. Last trimester, yes, if platelet count above 50,000, we can do C-section. From European perspective, even I consider here, if you can, yes, you can transfuse platelet to achieve the ideal platelet count, which is 80,000. But 50,000 is also safe, and in the European guideline, they consider 50,000 is the cutoff for LSCS. 30,000 is safe for normal vaginal delivery. If cutoff is not achieved, then pre and post-operative platelet transfusion to keep platelet count 50,000. Transamine should be advised. Avoid NSAID, especially we have to educate our anesthetists at the time of seizure that please avoid NSAID because they are very fond of using ketorolac. Avoid forceps studies, forceps use, avoid scalp clipping, blood sampling. Similarly, avoid epidural. Now, from newborn perspective, approximately 10% patient may have thrombocytopenia of those from those mothers who have ITP. Intracranial bleeding can occur, and neonatal mortality is less than 1%. If the newborn has less than 20,000 platelet, or in case of bleeding sign, give IVIG and steroids both. Mother often have a platelet count of more than 50,000 or even in the normal range because of the treatment she has received before delivery. So as I already mentioned, is a prothrombotic disorder. So thromboprophylaxis should be considered when count are really high with reduced mobility. Now the last slide, 20% of these patients with ITP have some underlying other autoimmune disorder like SLE, rheumatoid arthritis. 5 to 10% patients with CLL may have this issue. Splenectomy has lower long-term remission rates and it is worsening any pre-existing immunosuppression and increase the risk of infection, especially in the secondary ITP. So before embarking on splenectomy, one should please discuss in detail about the pros and cons of splenectomy in patient with autoimmune disorder. As a rule, treatment should primarily be directed towards the underlying disease. Thank you.
Thank you so much, sir. This was such a great presentation in which almost every aspect of ITP has been covered. Now for the next topic, we have Dr. Natasha Ali, who's an associate professor at Khan University Hospital. The topic she'll discuss is the role of thrombopoietin mimetics in benign hematological disorders.
Thank you so much, Nabiha. And Dr. General Parvez, thank you from my side once more. So I'm going to discuss the role of thrombopoietic mimetics in benign hematological disorders. And the conditions that I'm going to touch upon mainly are ITP and aplastic anemia. Let me just, right. So I have nothing to disclose. This is the outline of the talk. We are going to talk on physiology first. So we'll discuss the physiology of platelet production, the mechanism of action of these receptor agonists, the role of the thrombopoietin mimetics in immune thrombocytopenia. Then we'll just a couple of slides on the pathophysiology of aplastic anemia, the role of thrombopoietic mimetics in this disease, and a few slides on the work on thrombopoietic mimetics that one of my residents, Abdul did during his residency period here at AKU. So this is the physiology after the segregation from the master stem cell into two cell lineages to take the stem cell tree forward. Here is the colony forming unit, which is common for granulocytes, the erythroid lineage, the megakaryocyte, and the monocyte. And if you concentrate here, there are a number of factors that are involved from making the colony forming unit in the megakaryocyte go towards megakaryocyte and finally form a mature platelet. And these factors, the top here is your thrombopoietin, the stem cell factor, and then there are a couple of interleukins that play a role. And what happens is that thrombopoietin, which is produced from the liver, acts on the CMPL or the megakaryocyte receptor present in the bone marrow that causes the megakaryocyte to produce platelets, and then there is a negative feedback which causes the decreased release of thrombopoietin once enough platelets have been formed. And a similar mechanism is followed for the formation of red cells through erythropoietin. At the molecular level, when TPO or thrombopoietin binds here on the megakaryocyte surface, there are two domains, an extracellular surface and an intracellular surface. Once the binding of thrombopoietin occurs on the domain here, a host of signaling pathways get activated. So there's a SOX pathway, then there is the PIP pathway, the macrophage activation phosphokinase pathway, the tyrosine domain, which all get activated, eventually resulting in gene transcription in the nucleus and leading to formation of a platelet. And if we talk about the principle on which thrombopoietin mimetics or thrombopoietin receptor agonists work, then this is the same diagram, slightly different, but the same mechanism. So this is the cytoplasm of the megakaryocyte. This is the extracellular domain, and this is the intracellular domain. And these are the points of the CMPL or the megakaryocyte receptor where thrombopoietin comes and attaches. And this is the resting state where no thrombopoietin is attached at the moment. But when it eventually does, this is what happens is that all of the pathways that I just mentioned in the previous slide, which includes your JAK-STAT pathway, your SOX pathway, get phosphorylated, which in turn signals the downstream pathways to get activated, and the gene transcription occurs at the nuclear level where more megakaryocyte is produced and more platelets are produced. So if you concentrate here, this is mimicking what thrombopoietin does. So the hormone binds to these places which are present all over the surface. And if you talk about a mimetic, then there are different stages at where the mimetics act. So there is one stage over here, which is at the level of the receptor. Then there is stage over here, which is the transmembrane domain, which again, a thrombopoietic receptor agonist, where few of the other drugs act. So we'll talk in the next slides that the mechanism of action, or the point of action, or the point of entry of these different thrombopoietin receptor agonists varies according to the drug. And that is important, because if you want to switch your patient from one thrombopoietin receptor agonist to another to achieve a response, you can do so, because the point of action or the mechanism of action is slightly different across the drugs that we're going to discuss today. So just a slide on ITP. Dr. Usman just mentioned that it's an ancient disease, but it's poorly understood. And it basically occurs due to the antibody-mediated suppression of the normal thrombopoiesis, and that eventually results in peripheral platelet destruction. It usually has a benign course, but in about 10% approximately, you may find cases of severe non-intracranial bleed, which is epistaxis, mucosal bleeding, and about 2% may present with intracranial bleed, which can lead to a fatal course. These are the autoantibodies that are present in the in ITP, and at the megakaryocyte level, they don't seem to act a lot to cause the production of the megakaryocytes. Therefore, when you look at the bone marrow of a patient with ITP, you will see a lot of megakaryocytes present. But when these platelet attached autoantibody come into the circulation, that's where the problem starts to occur, where there is increased apoptosis, increased clearance from the liver, that leads to low numbers in patients with ITP. So this is the first study that I'm going to talk about. This is a patient, this is efficacy and long-term treatment of chronic persistent ITP with L-Trombopag. This was a clinical trial published in Blood by the name of Extend. There are about 302 patients, very few Asians, about 45 or 15% of the total population. The numbers that the researchers took to look at the response was less than 30. This was at baseline, between 30 and 50 and more than 50. And approximately 53 or half of the cohort in the study had received 3 or more than 3 prior therapies to treat their ITP. And if you look at the responses here, the blue bar shows you a platelet count of more than 50,000, and the orange bar shows a rate of more than 30,000, and these are the number of patients. So as the weeks progressed, you would see that almost 70 to 45% of almost 70% patients, or maybe bordering on 80, achieved a complete response or achieved a response of more than 50,000 or more, and this was present till the duration of the treatment, and about 87% or about 88% achieved a response of 30,000 platelet count or more with the persistent quota of the drug given to these patients. So the median platelet count was about 50,000, and this was achieved in 2 weeks as soon as you started treatment, and this count was maintained for more than 2 years. And they concluded that the problem occurred when people had received period therapies, especially splenectomy. They also achieved a good response, but somehow that response was lower to those patients that did not have prior therapies given to them before treatment. This is the next study, and this is a drug which is avatrombopag. This was a phase 3 randomized 1-2 design. So this was a double-blind study. Patients were randomized to 2:1 population, matching with the placebo. And the dose of avatrombopag was titrated, starting off from 5 milligram and went up to 40 milligrams. And patients who completed this arm then were eligible to go into the extension arm, which was an open label design. There was no randomization, and they achieved, again, the drug of 20 milligrams, and some of them also had their dose titrated. If you look at the response, then starting of the treatment in weeks 2, in the placebo group, none of the patients achieved a response, whereas in patients with the avatrombopag, which were 32, almost 66% of them achieved a response. Overall, the response rate in with this drug was about 65 to 67%, again, in patients who had received previous therapies as well. Romiplastin. So this is a drug which was mainly used in patients with chronic liver disease and thrombocytopenia, and patients who were planned to undergo a procedure and they needed a count boost of 50,000 and more for them to undergo that particular procedure. Various randomizations in this study as well, but a good number of patients, about 311, the response was seen at different points in time. Again, very few Asians in this study as well. And look at the number of prior therapies. More than 3 was about 162, or 17 in the total group of 311. And number of patients that received splenectomy and rituximab is given over here. So if you look at the results, so this is the placebo and standard of care group, and they have divided this into less than 1 year and more than 1 year. So clearly you can see a huge advantage. The maximum response that you receive, that you can see in the placebo group, is not more than 20%, whereas patients who have received romiplastin, the responses are sustained at 74 and 53% in less than 1 year and more than 1 year, respectively. So if you compare all of these drugs, this is a new kid on the block, which is losutrombopag, and not approved for ITP yet. But as always, whenever these drugs have come into the market, they have first been used in patients with chronic liver disease, and eventually they have been studied in patients with ITP, and then FDA approved for treatment in ITP. So this is undergoing trials in CLD, and from the looks of it, it seems like in a couple of years, this is also going to be included in the list of drugs that we can use. So this is what I was talking about, the receptor site of TPO action. This is important because if you want to switch from one drug to the other, you can do so to look at the response, because their sites of action is different. Only one has the subcutaneous route of administration, which is weekly. Otherwise, all others are oral drugs. Concentrate here on the cost. Exorbitant. And in Pakistan, we have L-Trombopag, which is available, and a treatment cost of 50 milligrams ranges between 60 to 75, or maybe 60 to 70,000 rupees for a month's treatment. Right, so moving on to aplastic anemia, just a slide. It's a clinical syndrome which shows that there is fatty replacement on the bone trephine, and all hematopoietic precursors are decreased, and this is how you classify the disease. The annual incidence quoted in Western literature is about 2 per million, whereas people present here or in the Far East, as General Parvez mentioned, the annual incidence is about 4 to 7 per million persons per year. The pathophysiology, so this is relatively newer cartoon that was published in 2017 in BJ Heme. So we all know that there are accumulated age-related mutations in a lot of patients with aplastic anemia that present to us. And these cells then undergo a T-cell lymphocytic attack or cytokine-mediated T lymphocyte attack. Few of these cells, what they do is that they escape the CTL attack because of their immunogenicity, and then eventually it is these mutant hematopoietic stem cell clones that cause that have a proliferative advantage, and then they eventually lead to complete destruction of the hematopoietic precursors in the bone marrow, leading to aplastic anemia. So L-Thrombobag, there were numerous trials published before this study, but this was a landmark study that was published in New England Journal of Medicine in 92 consecutive patients, which was a phase 1/2 study. There were 3 cohorts. So all of these 92 patients received ATG from days 1 to 2. And then all of these 92 patients also received cyclosporin for 6 months. Cohort 1 received L-Thrombobag starting from day 14 till 6 months. Cohort 2 received it till 3 months. And then cohort 3 received L-Thrombobag starting from day 1 when ATG and cyclosporin was started. And if you look at the results, so I've just put in the result of all cohorts, the overall response was approximately 80 to 82% in all cohorts across the board with L-Thrombobag. And this was sustained at a 2-year follow-up. And this was also done, and this was also correlated with the cellularity on bone profile. If you can look here, this was completely empty at baseline. At 3 months, it repopulated to about 30 to 40%, and at 6 months, it was populated to normal levels according to the age and the gender. Newer study published very recently where L-Thrombobag, so this study was for severe aplastic anemia, and after this study, L-Thrombobag was added to the triple regime of cyclosporin and ATG. After this, for moderate aplastic anemia or for single lineage cytopenias, L-Thrombobag has also been studied. So clear differentiation between patients who have received L-Thrombobag and prior immunosuppressive therapy. So the overall response here was about 50% for unilineage cytopenias in moderate aplastic anemia, and patients who achieved a response were then eligible for an extension of the study where the drug was continued for 6 months more. So the key points in this study was that it was well tolerated and it resulted in meaningful 50% responses with moderate aplastic anemia and unilineage cytopenias. And of course, the L-Thrombobag did not show any impact on the clone size or the somatic mutations that had occurred in these patients, which were done at baseline. L-Thrombobag has recently been studied in patients who have undergone a transplant and have not achieved the graft response as required at their center or according to the disease. So a lot of patients included in this cohort, but if you look at the ones with aplastic anemia, so they had single lineage dysplasias, some had bicytopenias, and starting L-Thrombobag resulted in a complete response at the end of 6 months. These were 2 patients, and there was one more over here at Fanconi's anemia who had transformed to MBS, also achieved a complete response at 6 months when L-Thrombobag was started. So this is the last part of my talk. I'm going to share AQ data. We have seen the response of L-Thrombobag in ITP and idiopathic aplastic anemia, and the PI of this study is Abdul Muqtadir. Thank you, Muqtadir, for sharing the charts and the demographics and the tables with me. So this was a retrospective chart review. The collection period spanned from Jan 2015 till 2021. This is how we assess the responses. ITP was defined as chronic persistent for 3 months with a count of less than 30, and this count has been taken from various studies and the clinical trials that have been published, and just shared them with you, and at least had failed 1 prior treatment. And for aplastic anemia, this was a necessity where the chromosomal breakage analysis, the PNH testing, the cytogenetics, the FISH panel for MDS was all negative, and that's how these patients were classified. We had included adult patients only. The post-intervention variables, so this is how the response was assessed. A good response was a count of more than 50,000 in immune thrombocytopenia. Partial was between 30 and 50, and no response was less than 30. And for aplastic anemia, again, the platelet lineage count of 30 or a stable platelet count that did not require any transfusion for 8 weeks. A rise in 1.5 grams of hemoglobin from the baseline or less than 4 units of transfusion for 2 months. And a rise of ANC by 100% or more than 0.5 at the end of treatment. And a p-value of 0.05 was considered to be significant. So this is the baseline characteristics. We had 32 patients for aplastic anemia and 29 for ITP. Again, as seen in various studies, a younger population for aplastic anemia, median age was 23 years, whereas for ITPs was approximately 50 years. Significant gender predominance, and at the bleeding scale that we looked at, you would see that the grade 2 and 3 were common for aplastic anemia and ITP respectively, and this again had a significant p-value. So response rates, we out of 32 patients in aplastic anemia, 29 of them achieved the recovery for platelet lineage, 27 achieved erythroid lineage recovery, 21 leukocyte and the lineage recovery, and 17 of 32 had complete responses with L-Thrombobag. And if you look at immune thrombocytopenia, a total of 29 patients, about 25 of these patients achieved a good/partial response. So 50 or between 30 and 50, and about 4 received, 4 of them did not show any response at the end of treatment. So the overall response rate for aplastic anemia was 53%, and for immune thrombocytopenia, it was 86%. So in summary, the introduction of thrombopoietin receptor agonists, bromiplastin, L-Thrombobag, and Evo-Thrombobag, and the one new kid which is still in the trials but should be available or would be available by FDA for treatment in ITP, has really shown a paradigm shift in the treatment of these two disorders. These are safe to use with few adverse reactions. None of the clinical trials reported any deaths secondary to the drug use. After that landmark study published in NEJM, L-Thrombobag was part of the triple regime for the treatment of severe aplastic anemia in patients who cannot undergo an allogenic stem cell transplant. And our data that we collected over from 2015 to 2021 showed a 53% and an 86% response rate for aplastic anemia and ITP, respectively. Thank you.
Thank you so much, Dr. Natasha. That was such a great presentation. Now we'll have the panel discussion and the question and answer section. If anyone has any other question, they can add on. I would like to thank all the panelists and ask the questions one by one. The first question I would like to ask Dr. Natasha is, what are the side effects we should keep in mind while giving the thrombopoietin mimetics?
Thanks, Nabiha. So few side effects are drug specific and few side effects are similar across the board. So the similar side effects include headache, fatigue, sometimes epistaxis, and these are common for all the thrombopoietin mimetics that I mentioned in the study. Then there are a few which are common to specific class of drugs. For example, L-Thrombobag, reticular fibrosis, which is reversible in most of the cases when the agent is removed, and then thromboembolic events, again reported with L-Thrombobag. For Evo-Thrombobag, the presence of arthralgias and myalgias is very specific to that drug. Otherwise, all in all, it has got a very good safety profile to be used in patients.
Okay, thank you so much, ma'am. So the next question is to Dr. Usman. Should we get the HIV testing done in the patients with in whom we are suspecting the secondary ITP?
Secondary as well as primary is a part of workup for any patient with thrombocytopenia. However, it mostly driven from the experience of the West, where there is a high prevalence and incidence of HIV infection. Somehow, it is we should consider always whenever there are, say for example, because as I already mentioned, the ITP is a diagnosis of exclusion, and usually patients has no symptoms other than this hemorrhagic manifestation. Otherwise, there is no B symptoms or any other constitutional symptoms. But yes, if there is a high index of suspicion, then one should go for HIV testing.
Okay, sir. Sir, another question. What is the significance of immature platelet fraction in the diagnosis of ITP?
अच्छा देखिए, numbers are the most important, बाकी सारी चीजें secondary हैं. Say for example, whatever the immature fraction हो, अगर 5,000 से कम हो प्लेटलेट तो numbers पे जाएंगे ना आप. तो एक तो ये हो गया. Immaturity और maturity का ये कि that depend के भाई जो MPV कहते हैं, mean platelet volume, और immature platelet का जो है वो depend उसी पे करता है कि what is the underlying pathogenic process. Say for example, we all know कि जिनका मैरो करते हैं तो वी आर एक्सपेक्टिंग दैट बाय मेगा कैरोसाइट प्लेंटिफुल ऑल दिस थिंग. तो इसका मतलब यही है कि दैट इज जो है कि फेवर इस बात को करता है कि यस एमपीवी वगैरह बढ़ा हुआ होगा और वो कॉन्स्टेंटली जो है जो भी डिस्ट्रक्शन हो रही है दैट इज कंपनसेटेड फ्रॉम द मैरो. इन एप्लास्टिक एनीमिया यस ये सारी चीजें जो मैच्योर जो फ्रैक्शन है वो लो हुआ होगा एज कम्पेयर टू आईटीपी. तो उसकी है सिग्निफिकेंस. ऐसी बहुत सारी चीजें हैं, बहुत सारी गई. प्रैक्टिकली देखें ना तो नंबर्स की ऑब्जेक्टिविटी बनती है जो अभी अब तक एस्टैब्लिश है. किसी चीज ने भी उसको ना ओवररूल किया नहीं नंबर्स को जो प्लेटेड है. ना एमपीवी ने किया, ना इमेच्योर फ्रैक्शन ने किया, ना इमेच्योर रेटिक ने किया, कुछ नहीं. सीधे सीधी जो चीजें चल रही है ना अभी तक वही चल रही है भाई. थैंक यू.
Thank you, sir. Sir, another question is from Dr. Bushra. So if the patient is a pregnant woman and she has a history of VTE and she had been on anticoagulation with the inox and then she started to drop the platelet, what should be the clinical pathway we should use in such patients?
भाई देखें, सबसे पहले अगर ना कोई अगर हेपरिन पे है फॉर वॉट एवर, चाहे वो अनफ्रैक्शनेटेड और फ्रैक्शनेटेड, तो सबसे पहले हमारे जहन में क्या आएगा? से फॉर हिट आएगा. ठीक है, हेपरिन इंडूस थ्रोम्बोसाइटोपेनिया. तो हमारे पास क्या है? हमारे पास यहाँ पे अवेलेबल है डोज ऐसे वो हम कराएं जरूर. फिर आपको पता है कि इसकी स्कोरिंग होती है T4 स्कोरिंग फॉर हिट. उसके आप क्राइटेरिया फुलफिल करें कि भाई विद इन 5 डेज हुआ है, उसके बाद हुआ है, मोर देन 50% हुआ है कि नहीं, ये ऐसे इसका पॉजिटिव आया है कि नहीं, कोई थ्रोम्बोस कहीं रीसेंट ऑनसेट की कोई थ्रोम्बोसिस तो नहीं हुई. ये सारी चीजों को देखें. अगर वो हाई इंडेक्स ऑफ सस्पिशन है तो डेफिनेटली आपको ना एनॉक्सिप्रिन हेपरिन आपको रोकनी होगी, नंबर 1. नंबर 2 जो है, फिर आपके पास जो ऑल्टरनेटिव जो है वो है फोंडापेरिनॉक्स. वैसे तो बहुत सारे एजेंट है अवेलेबल, बस आपके पास फोंडापेरिनॉक्स कभी अवेलेबल होती है कभी नहीं होती. दिस इज सेफ both in HIT and even in renal insufficiency and other cases. एक तो ये हो गया. नंबर 2 जो है, जो अगर हम देखते हैं इसके हिसाब से, अभी तो प्रेगनेंसी की बात कर दी, पर ना आजकल ये हो गया है कि 50,000 से ऊपर आए प्लेट आप रेवरॉक्स पे डाल दें. क्या है?
सही.
Okay, thank you so much, sir. Ma'am, there's one question from you. What is the success rate of L-Thrombobag in the patients with ITP?
So like shown in all the studies, it ranges between 75 to 80% approximately. And the duration of treatment is, it takes about 3 months, 3 weeks to 6 months for the response to be attained once L-Thrombobag is started. And once there is a response, then you need to continue it for 3 to 6 months. Following this, there is another question on the same lines. So at AKU, the study that I showed, we continued the drug after the response for at least 3 to 6 months. So what we did was we stopped the drug at 3 months and then we monitored, and if the platelet count remained stable, then we did not restart the drug. If the count dropped, then it was reintroduced and carried on for 3 months more. So a total of 3 to 6 months in all of the patients.
Thank you so much, Dr. Natasha. Now I would like to invite Dr. Tahir Shamsi, who is a professor at NIBD, for joining us. And can you have some comments, sir?
Right, thank you very much, Professor Salman and Dr. Natasha, for organizing this webinar. I was discussing with Natasha earlier that the quality of presentation, especially in Parvez, and then followed by Uzma and Dr. Usman and Natasha. This all shows where the hematology has reached in Pakistan. This is pretty high-class work being done here, and now we are getting regional publications of top-quality presentations published worldwide, globally, and then presented here. So this is really, we have moved forward, and this COVID, I was seeing the number of participants, there were more than 125 people who were connected with this webinar. And then I also checked at NIBD and I asked who has joined. So there was only one connection, and there were 7 or 8 postgraduates who were sitting and listening to the whole webinar. So in fact, 125 plus, I don't know how many more joined together. So webinar or this current technology is allowed us not to be present physically, but actively participate in these scientific activities. And certainly such programs every month or maybe every 2 months will give us the opportunity to learn and share whatever is going on in the country and around the globe. So congratulations once again, Dr. Salman and Natasha and the whole team who managed to organize this webinar and allowed us to learn many new points in this benign hematology. Thank you.
Thank you so much, sir. Now there's, I would like to ask one last question from Dr. Parvez. Sir, what is the cytogenetic studies in aplastic anemia, which helps in determining the prognosis or transformation to leukemia?
There is no specific cytogenetic abnormality that is associated with the idiopathic aplastic anemia. There are certain genetic markers and cytogenetic abnormalities that are associated with evolution, especially the cytogenetic abnormalities involving chromosome 6 and 7. They herald the onset of some leukemia or MDS. Similarly, DMNT3, AXLX1, and big A, the abnormalities, they all indicate evolution, impending evolution into either MDS or acute leukemia.
Thank you so much, sir. Now I would like to invite Dr. Salman Adil, who's a professor at Khan University Hospital. Sir, I would like to have your comments, please.
Right. Thank you very much, Nabiha, for moderating this event so nicely. I would like to thank all the participants for delivering excellent talks and in fact delivering on the topics which are basically day-to-day problems in hematology practice. And General Parvez, especially General Parvez, Dr. Usman, Dr. Uzma, and Dr. Natasha for delivering their original work, in fact. And it was nice to see more than 100 participants, in fact, more than 125 participants benefiting from this academic activity. So I hope that we'll try to continue with such academic sessions and also sort of getting the topics delivered on common benign hematological disorders besides the more advanced hematological things. Thank you so much. Thank you.
Thank you so much, sir. So at the end, I would like to thank on the behalf of my institute, Khan University Hospital, to Mr. Imran Waheed from Pakistan Society of Hematology, as always, for his hard work and support, and also to Novartis Pharmaceutical for supporting this educational activity. And at the last, I would like to thank everyone for joining and
just a last comment, Salman.
Okay,
Natasha, is it possible कि ये जो recording आप कर रहे हैं ये available करें in the वो हमारा जो forum है उसके ऊपर?
जी, sure, sir.
हमारा WhatsApp group है उसमें अगर available करें तो ये बहुत nice collection है और comprehensive जितनी भी है.
बहुत ही यूजफुल है. जो लोग अटेंड नहीं कर सके अभी तो they can always go back and connect it.
वो ये मैंने कहा ना ये कि डे टू डे कॉमन प्रॉब्लम्स के ऊपर बात की हमने which was I think which would be benefiting most.
उसमें डाल दें हमारी वेबसाइट पे डाल दें PSH की.
ठीक हो गया.
जी सर.
बिल्कुल ठीक.
Thank you very much. Thanks a lot.
Thank you so much.
Thank you.
Thank you very much.